Okay, we are here with eminent colleagues. This is a wrap-up interview at TCTAP 2025. We had a remarkable session, very animated on main stem, but of course, main stem is also part of the story of the tree-vessel disease. And we have Andrejs with us and David Taggart, and of course, the master of the ceremony, S.J. Park.
Yes.
So we have a few questions. I think that you are the only speaker which is present in these wrap-up interviews, so that's a privilege, and we will take advantage of that. What was your feeling about the session?
Right, it was good. I think we are changing now. After the personal, I think ischemia study, and even in the David, you mentioned about even in the multivessel, the bypass surgery. However, if you look at the 2023, 2024 guideline concern, in low syntax scores, low, anatomic complexity for those patients is at least 2B, 1A in terms of a PCI. So I personally think it's getting better rather than we review the old data, something like that. And so we'll talk about the first three, how to manage, how to, PCI versus surgery and medication. And
I think there were major statements, S.J., during that thing, and an important statement from people who have been in the field for the long, long time. We are all opinionated. We are coming with a different background. I mean, it's amazing what I've been working with a surgeon in my young career before becoming an interventional cardiologist. So I know how they feel. I mean, it's a training which is very, very demanding, probably a little bit more demanding than the interventional cardiologist. And then to see suddenly in the 80s and 90s, to see the interventional cardiologist getting involved, that must be some reaction. Fortunately, the heart team was there to say, there are cases who can go to interventional cardiology and cases who can go to PCI. And my first question for you, do you agree that tree-vessel disease and main stem are two different animals? Of course, coronary artery disease is a continuum. We all agree about that, but it seems that there is a boundaries between something which is above 3.5 millimeter and something which is more distal and difficult. Do you agree with this statement?
Yes, I completely agree. And I have to say first to congratulate Dr. S.J. Park, not only for this great meeting and the 30th anniversary, but also the fundamental work he and his team have done on left main stem stenosis. And he has shown us, as you have Dr. Serruys, in the syntax trial, there is a real difference between left main disease and multi-vessel coronary artery disease. And I think personally, for left main disease, if it is ostial or mid-shaft without involving the bifurcation, it's a very different disease from multi-vessel coronary artery disease.
You believe it's more something, at least for the ostial, which is related with the aortic disease. Main shaft is quite rare, to be honest. And I must say that bifurcation with OCT and IVUS and all the rules that the people are building, the last speaker was emphasizing the plaque burden and the MLA. I think that we are making progress in the bifurcation because it's still big vessel. But of course, it's still, quote unquote, a bricolage.
Yes.
I mean, you have one piece of metal, a second piece of metal. We have never created an optimal treatment for a bifurcated main stem.
Yeah.
So there is still, you see, all this meeting is about the bifurcation, the technique used, and it's unclear. You have the French people with the provisional, you have people of the Far East, which is more for tute. I think that your colleague who was trying to make the rule one provisional and one two-stand, that was a very good start, a very important communication this morning. I have another question for you. And of course, Andrei, you can interview at any time. You were not speaker this morning, so you are the free speaker now. The second question that you have, you know, I've been working with the surgeon for many, many years. When I saw the debate on Excel, I felt that it was important to have somebody neutral, which is above the surgery and above the interventional cardiologist, that Jean Brunwald. And I tried to bring 4 trials to the TIMI group, and we succeed. It was an exercise of diplomacy that we could use in the Far East, the Middle East, and everywhere. But finally we did. And I was very impressed when they found that the hazard ratio for mortality is close to 1, even a little bit less than 1, but then at 33, that's the explosion of mortality and other catastrophe. Do you accept this conclusion?
No. And 2 reasons why. The first is I will go back to left main just for a second. And Dr. Park's work in the main compare registry showed very different outcomes at 10 years if you had distal bifurcation lesion of the left main versus ostium in mid-shaft, similar to what Dr. Columba's group had shown. The second reason I am very skeptical about these meta-analysis of randomized trials, I think they are dangerous for patients. Because most of the patients in these trials have a median syntax score of 25. So it's telling us what you showed, Dr. Serruys, in the syntax trial. If you have low severity left main that doesn't involve proximal coronary artery disease, then treatment by stenting is a great option. And with that, I completely agree. But the way the trials are now being presented is they're being written as they apply to all patients with left main. I think from that perspective, it's scientifically wrong. I think it's academically wrong. And I think clinically it's very dangerous for patients to be given that information when it does not reflect. So we know in clinical practice, 2/3 of patients have syntax scores above 33. So to present papers suggesting that treatment of left main is the same for all patients, I think is very dangerous.
Right. So, yeah. SJ.
Yeah, no, it is really fantastic because I grew up from first meeting with Patrick when he created a syntax study, and this is very interesting. You see, I guess it's very depends on, as Patrick says, from you are coming and where you are. And why I'm saying, because Latvia is a small country and we know each other. We know each patient and patients know us. And this is very interesting how grow up also and what was, how push the syntax, both parts, and interventionalists and surgeons. And actually it really was a game changer. And what I really like to a bit to, how to say, I slightly disagree, or I really disagree with David, my very good friend, because as Patrick mentioned, it is very rare. First of all, different animal, it is osteal left main, because completely different tissue.
Yes. Yeah.
And actually it is sometimes much more difficult to improve or to fix if you compare with bifurcation. With bifurcations, we did so many trials. We have so many ideas how to deal with that. And but there is one other point. Even in the most challenging left main gives you not more than 20, 21 syntax points. Yeah. The problem is, and this is the problem is actually the ciliary artery disease, long lesions, calcified lesions, and maybe sometimes lack of
Let me go back to something that David has said, which is very important. What we have seen, you mentioned a meta-analysis. You know, you can only find one meta-analysis under my name, and that I never done the second one because it can be terribly misleading. I agree with you. But you were talking about the syntax score of 25. That tells me everything, because in the randomized trial syntax, it was 28.
Yes.
But in the registry, it was 10 point more, 38.
Yes. Yeah.
And the last study that we have done with the surgeon, which is fast track cabbage, the mean syntax score was 48.
Yes. Yes.
You see? And when you see this vessel, I didn't find any interventional cardiologists who want to do it.
Yes.
You know, 2 bifurcation, 2 total occlusion, forget about that. Now, it's clear that if you have a 3-vessel disease without total occlusion, without bifurcation, with focal lesion, it works very well. But the big things is, what about the vulnerable plaque proximal to the stent? And what is the the vulnerable plaque distal of the stent? That's where, analyzing again the 3-vessel disease and the main stem, we found that surgery protects you quite well. You know, it's amazing to see by CCTA and NFFR what you see in the proximal segment to the anastomose, to the distal. The distal is almost perfect. It's amazing. There is something funny in the coronary artery disease, that everything is proximal, and at a certain point, it's okay. And then looking at the vessel that the surgeon didn't treat or defer. That's very, very important.
Right. So, Dr. Serruys, I think this is very important. And I think it explains that over 3 decades, despite the technological improvements in stenting, it has still not been able to match bypass grafting. Because bypass grafting doesn't only deal with that proximal lesion, it gives prevention against future disease progression. And coronary artery disease is a progressive disease. So I think the fundamental difference in these techniques is that, plus the fact, if you put an internal mammary artery onto the left anterior descending, the most important vessel on the heart, it provides a constant source of nitric oxide, which Dr. Ruscher showed in the New England Journal in 1988.
And I was the reviewer.
That it protects, it stops further disease development. So if you take these 2 factors into account, I think it explains why, despite the enormous technological advances in stenting, it still doesn't match coronary bypass grafting.
Bypass surgery, technical-wise, is improved exactly the same way during the last 10 to 15 years, actually. We have a contemporary PCI, the imaging-guided and FFR, physiology-guided PCI, totally different concept, we made it. And so I believe ischemia study and FAME3 study, anyway, the conjunctions, they included the concept of FFR and imaging-guided procedure. And so I believe ischemia study is a big impact in the practice-wise, in the current practice. And so, Bangalore, what do you, after the ischemia study, the main and multi-vessel disease clearly basically and surgical disease, right? I think so. And however, what's been changes?
Dr. Bangalore has joined us. He was one of the speakers. He was a little bit late, but okay. So we have questions for you. Okay. And the first question that I have for you, what is the best strategy to justify a complete revascularization? An invasive pressure-derived FFR during the procedure, an angiography-derived FFR during the procedure, a multi-slide CT scan, all above of something else.
So, first of all, fantastic question. So I think we all agree on this, that complete revascularization is key. And, at least in my clinical practice, and the decision for PCI versus CABG is purely, one of the major reasons is, can you completely revascularize with PCI? And if the answer is no, patients are better off with bypass surgery. So if you now come to PCI, what should we use for complete revascularization? I would say it really depends on whether it's acute coronary syndrome or stable ischemic heart disease. Acute coronary syndrome, I'm still not completely bought into the fact that physiologically derived completeness revasc is superior to anatomic, because of the concept of vulnerable plaque, thin cap fibroateroma, and the complete 2 hopefully will answer that question, comparing ischemia, FFR-derived physiological-based complete revascularization versus angiographic. If you look at stable coronary disease, it's still controversial, but at least in the ischemia trial, we showed that anatomic complete revascularization had superior outcomes when you compare with the conservative strategy, and it was actually superior when it compared to invasive strategy with incomplete revascularization. But regardless, I think complete revascularization is the way to go.
I have a question for you then. Very soon, I think, mainly with multi-slice CT scan,
Right.
we will have to have what we call LV% myo, the flow going to that region.
Yeah.
And you remember in the past with radionuclide technique, it was said if the territory is less than 10%, you can neglect it, it will not be a killer.
Right.
Are you still of opinion that it is like that? If you have something which is, let's say, 6% myocardial territory in a secondary diagonal, are you going to go for it or going to say no?
Yeah. No, I think the concept of reasonable incomplete revascularization, which you're pointing out, I think it's critical, because if you go after, for example, in the live case we had circumflex artery, right? If it is supplying a small territory, there is no point in saying that we're going to completely revascularize every segment, especially if it is supplying a small territory. I think.
Dr. Serruys, if I can make a comment from a surgical point of view, I think the use of FFR is potentially dangerous for patients. If you look at the Syntax trial, which you led, the most definitive trial showing the benefit of coronary bypass grafting, it was done on angiographic stenosis. It wasn't done on FFR. And the problem with FFR is now, in many patients, it's being used to downgrade 3-vessel disease to 2-vessel disease.
Yes.
And this is dangerous for patients. And furthermore, it means, again, to go back to a point I made, the benefit of CABG over the longer term
Okay, now
is
I'm
placing
going to
bypass grafts.
It's my turn to interrupt you.
Okay.
I think that
Totally
when you have something which is physiologically not significant, you take a risk on doing something surgically or by PCI. That's point number 1. Point number 2, at that moment, I said I don't have a justification to treat that vessel. It's not generating ischemia and probably not angina. But I'm worried about what we call the vulnerable plaque.
Yes.
And there,
Yeah,
I must say that I was disappointed this meeting and the meeting that there was nothing about secondary prevention.
Right.
You will see in the future, you know me, you will see CCTA study where we show regression of the plaque in this kind of patient with soft lesion and so. I call that a new terms.
Right.
And the new terms is pharmacological revascularization.
So I completely agree, but let me just go back to one point.
Let me also to put one small.
It became animated
because
for an interview.
I guess it is a really, really important point. And this is and you asked why we are not talking about secondary prevention, because actually we didn't teach our students or in interventional cardiologists. And what I see very often, they are not taking care so much about what you call this pharmacological treatment. And this is, or vessel treatment. And this is important. It's really important.
Look at the time.
All right.
Our time is finished. we will not give the last word to David. It will be too dangerous.
Don't
but
worry.
the last word to you.
Don't worry.
Yes,
We're gonna,
I agree.
David, basic concept of FFR, you just mentioned about the dangers, right? Basic concept is FFR actually is ischemia guided. Ischemia guided. Even in the angiographical history vessel disease, after the FFR, we make a 2 vessel disease, sometimes single vessel disease. The meaning is we want to treat based on the evidence of ischemia. That is basic concept of FFR. So, and we have some big, large registry data. Look at this. If any percent stenosis and D4, negative FFR, the hard endpoint death or MI is 0.2% per lesion per year.
Yeah.
It's totally negligible, non-negligible. Right? So anyway, very low. That is simple, right? Negative FFR, just the D4 is very safe for the patient, right?
But Dr. Park, I have
Right.
to say, I know we're finished, but this is for us. We argued that the criticism...
You promised not to have the last word.
Okay, well, but the criticism of syntax was it didn't use FFR-guided PCI and it didn't use the best stent. FAME 3 used the best stent and FFR-guided PCI, and Cabbage was still completely superior.
Yeah, if I
Between
can,
the guest and the host,
Sorry.
the guest must have the last
And
word.
this level.
Sorry, Dr. Park.
yeah, but,
You know, he's the only one in this debate who used percentage. That means he knows the field very well and he's telling you the truth. That will be my last word. Thank you very much.
Great debate. Thank you. Thank you.